I think we will start.
And I can start without a mic.
You can start without a mic.
It's up
and
to
you
you.
can introduce us. Great.
You don't mind?
Here, I can give you this.
Do we want to show your screen?
Yeah, let's show our screen.
Because
we'll
given
have
this
Don
is the
Tebow
Open ID
introduce us.
Foundation.
Can you show our screen? Thank you.
Good morning. The Open ID Foundation's been managing a couple of tracks. This is a particularly important one. What I think is important about it is that it is showing what is now, we believe, to be a mainstream standard, Open ID Connect, now being optimized or being profiled for what I think of as the gnarliest problems in identity, which is healthcare and provisioning of healthcare records. So luckily and importantly, we have two experts and two leaders of one of the most dynamic work groups that we have at the foundation. And I wanted just to, again, note that in this particular sector, progress in identity is only going to be coming when there is a public-private partnership between regulators at the federal, state, and local level and the private sector. And in the leadership here, we have representatives of both. So I'm really delighted that Eve and Deb are going to be taking you through this progress report. So thanks again for coming. And ladies?
Take it away, Debbie.
Okay. So,
No, these are normal. These are normal shoes today.
for a show of hand, do any of you not know of the Heart Work Group? Okay. So I'm from the United States Health and Human Services Office of the National Coordinator, and our main role is actually the movement of clinical health data and health data records. But also, I have a focus on privacy security around consumer-mediated, patient-mediated exchange.
What's going on?
Wait.
Why is it cutting in and out? Is it our problem up here? Hang on one second. Technical difficulties.
Is it my badge?
Shouldn't be. I think it's just where.
Because I put it in my pocket.
Should be.
Is that better? That's worse. How about now? Okay.
Just hold on to it.
So, and there's been some progress with moving health data, but there's been this movement around getting patients and consumers more engaged with their data.
I suggest you just get her a handheld mic if that's all right.
You know, I talk really loud. I don't almost need a mic.
They're recording, unfortunately. Thank you, Don. Singers, maybe we can entertain you with a song.
If the two of you don't have good mic,
So do I want to undo this?
Sorry about that, guys. All right.
I feel more comfortable with a mic like this anyway. So we had a series working. We collaborated with MIT and the health community and privacy and security folks, and we came up with an idea that we realized that to work with open APIs and aggregation of health data, not just. Did you hear me? Okay, not just healthcare data, but health data, that it was more broad, and there was aggregating data of other sources that we needed to have some defined profile of profiles of standards to support it. And we realized not just OAuth and OpenID Connect, but we also needed to look at, from a patient's point of view, consent and authorization. So we also looked at the possibility of UMA as well. So that was the beginnings of the works group.
Right, so hopefully this mic will work. So I'm Eve Mailer, and I'm with Forgerock, and I'll just project clear bell-like tones, as I was taught in high school. And I sort of represent a private sector view. Co-chair this new group at the Open ID Foundation, and HEART stands for Health Relationship Trust. And so apparently unique in all of the efforts around health-related data flowing, this effort has a focus on patient-centric, privacy-sensitive, restful health data sharing. And what I'd like to show you now is actually the charter for this group, and this is on openid.net. We just chose to show you web pages about our work and other artifacts in the sort of tradition now that we don't use slides because we might as well show you the latest of what we're doing. And it's actually kind of exciting. So our charter reflects our goals for internationally acceptable, as I say, restful, privacy-sensitive, patient-focused, not provider to provider, where most of the standards efforts have focused, profiling of existing specs in the main. So what we're doing is we're profiling this kind of emerging set of standards, including OAuth and OpenID Connect and user-managed access, and also this vertically oriented RESTful API, the FHIR API. Who here hasn't heard of FHIR before in this particular context? Okay, it's not spelled how you might think, F-H-I-R, Fast Healthcare Interoperability Resources. It's an interesting API defining essentially electronic health record, personal health record, and can be other health-related data flowing across these now familiar kind of web API channels. So once you have an opportunity in this patient-centric context to profile how these work, you to, for security reasons, for interoperability reasons, for consent and authorization and delegation reasons, you need. That's what we're doing. So I'm going to sort of flip through a few tabs to show you the use cases that we've built, and I'll rest upon the, no pun intended, the last one that we're still working on quite heavily. And maybe, Debbie, you can comment upon each of them as I go through.
Outside, I'd like to make.
Oh, right, no, we have this, which is very new news.
Also, like point, and it's so the user group. We actually have pretty good attendance. Typically, 15 to 20 groups that are from both health, IT, security, and privacy that are attending. And we also, on our list, there must be close to 150 that are actually monitoring the list. In our recent profile, when we would put it out for the vote, I was very worried that we wouldn't make it. And I was very surprised to see that we had a number of those from the health IT world that's been monitoring the list and not actively participating, actually joining the foundation to get their vote in. So we do know that we're having great participation at it. And ONC is one to try to help move the market and move it together. And one way to do it is we just announced a challenge called Move Health Data Forward. And part of that challenge is actually to get the consent of a patient to be able to actually move their data. And the award pack purse is around $250,000 and maybe a $75,000 award for an individual group. But it was really encouraged yesterday. We had our first our webinar about what was going on about it. And we had over 250 people sign up, 150 people actually being who was interested in that actually attended the webinar. So there is real interest in getting patient data moving, and so we're hoping that this might encourage that environment.
This is extraordinary. Numbers like that at a webinar, I think, are really amazing to show interest. And with numbers like this, soon you're talking real money here. So some of you may be interested in actually putting your names in submission for the challenge.
And actually, for those who may be interested, we're actually looking for partnering relationships because the health world really needs partners to be able to move some of that forward. And there, at the challenge, the challenge.gov, there is a group that you could possibly join and volunteer to be able to partner.
It's one of the most exciting things about health IT, I think. You know, Health Level 7, the large standards organization, I mean, it's done great work, but it's very slow moving, I have to say. When you do something like a RESTful API, like they've done with Fire, this is me kind of looking in from the outside, working for a kind of horizontal identity stack. You do a RESTful API and you can start having hackathons and things happen quickly, and that's something that you don't typically see in health IT.
About your layered approach before you
Yeah, let me show the layered approach here.
That's important.
All right, so let me show you this diagram for how we're profiling these existing specs. So if you're familiar with this, what I think of as the emerging technology stack of kind of the RESTful API era, OAuth is kind of security and authorization API, and you can protect any API with it. OpenID Connect leverages OAuth to protect a particular API, a kind of identity and single sign-on API, if you will. So it comes with an API. UMA, user-managed access, is built on top of those other two technologies, but it too, like OAuth, can protect any API. Now, what we're doing in HEART, what we're developing in HEART in the way of profiles, because of that arrangement of any API versus comes with an API, we're actually developing a series of profiles, some of which are related to just the security and basic interoperability of OAuth, OpenID Connect, and UMA. And in fact, we have delivered draft profiles for those three technologies. And we are also developing what we're calling semantic profiles in the context of the particular sectoral API, Fire, as an exemplar for what may be other APIs in the health space.
And we did this purposely for the idea that the first three that are in implementers draft, that for other working groups that are working on similar, that our hope is that there be a common base that we all can work from, and that these drafts, this would enable, it gets by the IP to be able to offer these profiles to the other working groups. And we're really concerned about the harmonization across these, the better that we can harmonize. For at least example, for healthcare, it is not just the provider or the patient, but it's also government. It could be international. There are a lot of groups that we need to work with. So the better, if the core profiles that we can align on, I think would be very important. And then the API that we're focused on is Fast Health Interoperable Resource. And think of it as the APIs that allow you to get discrete clinical data. And that's essentially what we're focused on for this group.
So let's show folks some of our use cases that we've been working on. An initial one, hopefully you can see this, I'll make it bigger. This one just focused on OAuth flows specifically, but the idea is that our typical user, Alice, we know her well, would register with a primary care physician and set up an initial two-way exchange of personal data between an electronic health record and a personal health record. And I'll just show you the table of contents here just quickly. But you can see that there's some flows that are meant to evoke certain goals so that it would inform what we do with profiling. And I'll just show you these quickly so we don't run out of time and we leave time for questions.
And just to quickly talk about, this touches on something that you might be called about the virtual clipboard. The idea that every provider that you go to, there's this clipboard that you're handed and there's basic information that you hand out. And if you go to 10 different providers, you need to provide it at 10 times. Wouldn't it be wonderful if there were ways to automatically be able to relate that information? And this is kind of tied to that.
And then another one is the multiple portals use case. And this is the idea that we all deal with multiple electronic health record portals. And it would be a wonderful idea if we could unify our experience of managing authorization to all those portals. These are some of these are actually older ones, and I pulled them from all kinds of places, so I'll go quickly through them. Post myocardial infarction, implant and rehab, so we're getting into some little bit of IoT here. This was a Veterans Administration secure RESTful use case. I don't actually remember talking about this one too much, but here we got to Dr. Pat Feelgood, and Dr. Sam Pellegrino. Into the more modern use case, elderly mom with family caregiver. So you're talking about how you give a proxy to somebody who helps you. And then finally, the one that we're working on right now, and this is a use case explicitly involving UMA and the FHIR API. Alice selectively shares health-related data with physicians and others. Yeah,
Right,
go ahead.
and I just, the reason we're, the use cases, because we're such a diverse group that either very technical, very health IT oriented, it's really difficult to get everybody on the same page about what is the use case and what are the flows to even have them visualize what maybe the technical flows and specifications may be. And that is really what we're using those use cases as a driver for, to be able to develop that.
There's a talk that I've done recently, there's actually a video of it online where I've walked through quite a lot of the data that's buried in links here. So if you're interested in that, after the talk I can sort of point you, we can actually make all these links available if you like, maybe put it on the homepage of the HEART work group, and you can dig through these links, but I can point you to the video if you're interested. So we've talked about that. I just wanted to point you next to the actual current specs, which are all also linked from the site. So this is the current post-implementer's draft spec, the security and interoperability base spec that profiles OAuth. And we've gotten some comments on even this version of the spec, so we're digging through those now.
At least 27 comments, right?
At least 27. It's a great conversation, and these are really important because there's a lot of implementation experience with OAuth. There's actually a whole OAuth threat model document. There's new practices that we're trying to learn about when it comes to health circumstances. There's a lot of people building with, there's an open source FHIR server you can play with. So this is great experience to try and learn from, and we're doing that. So here's the similar spec for the HEART profile for OpenID Connect, and again, the similar spec for the HEART profile for UMA. And then finally, this is not implementer's draft yet, and so implementer's draft is an OpenID Foundation term of art, meaning it's received a certain level of kind of balloting and intellectual property review. So this is earlier stage, but what we've done with the HEART profile for FHIR is we've taken some early work on proposals for OAuth scopes for the FHIR API. The FHIR API was published without any recommendation as to how to secure it. And so another group recommended OAuth
The Argonauts.
and recommended scopes. And we've become the group to take that forward. And so what we've done is we've taken those scopes and done kind of a swag at what the scope should be. And there's much more to come on that. And further, there's much more to come in terms of writing a specification, a profile for UMA, scopes, and much more.
And actually, we've had some feedback from, we're a consumer-mediated exchange, but there's an effort on the provider side to be able to adopt this open API across all different electronic health record systems to make interoperability easier. So they came up with some base scopes to start with that we leverage. But what they're realizing that it's not fine-grained enough, and they're not sure, especially for patient interactions, what it is to be able to respond to consent and authorizations. Do they want to see more? Do they want to see less? There's some real concerns that we haven't covered the full scope of that. And
No
there
pun
is some
intended.
hope within, there is some hope within the work group that we could kind of flesh through some of those issues.
And just to give one example of the kind of thing that real life sort of introduces you to, the scopes that are presented in this work, this profiling work, include kind of basic read and write for different populations. However, when you come up with a use case like we do in the one that we're working on now, the different flows for the UMA use cases, what if you want to do data donation for clinical research in a de-identified fashion? Really good use case, something we want to support, and something we know that those who publish APIs are going to be incentivized to support. Well, if you want to share that kind of data in that fashion, to distinguish between sharing it in a de-identified fashion versus, I guess, a normal identified fashion, you need to be able to support a scope that distinguishes between de-identified and identified. And currently, that's not distinguishable in the scopes. So these are things that we need to think about if we want to present them as interoperable and standardizable. In order to leave enough time for questions, we've got one more tab we want to share, which is about a particular implementation that's been worked on of these profiles. Debbie, you want to talk about this?
So as part of it's not just the profiles, it's the idea to encourage implementations. So there is the MITRE OpenID Connect, that source code that Justin Richer and Sarah has been doing a lot of work on.
Sarah Squire here in the second row.
She in the
I
front.
embarrass you.
We also have a working reference implementation if you want to look around at healthauth.org that has kind of semi-working. We're working on having test tools to be able to test, because what we're finding in the health community, OAuth is really hard. It is really hard to get them to wrap around the different flows and how things move. And so so it's not just having the profiles, but having tests in different source and libraries for them to use. We really think it's important to be able to spur the community.
So with that, I think we'll open up to any questions or comments you might have. Yes?
Curious how the HART working group work overlaps with or competes with the SMART specification, which also seems to be building on top of both FHIR and OAuth 2 and OpenID Connect.
Yes, so so you're probably familiar with the Argonaut work group?
Yes.
So if you are familiar with the Argonaut work group and following the Google, do you follow the list, the Google list?
Folks on my team do, I don't.
So what they have actually done, and I think, Sarah, you were involved, they did an actual work between looking at looking at the Argonaut profiles and the HART profiles, and we see, because they're two totally different use cases at the moment, SMART is more about the clinical inside, you want to show apps within your clinical situation, and they're not more focused about the cross-organizational exchange, at least for the short term, that they figured in the long run, depending on the use cases, that there would be more alignment. For right now, they're figuring within somebody's borders, it doesn't need to be as secure as if you're exchanging across. If you're looking at the SMART work, and I think it's called the cross-organizational profile, you will find it closely aligns with some of the work that's in both the OAuth 2 and OpenID Connect work that we have here.
Yeah, there's
especially
actually
using JOT.
There's a couple things. There's a lot of liaison, actually, mostly informal, but some formal, because the Smart on FHIR OAuth scopes are what we've based our profiling on for this last spec. Yeah, and the profile work that Smart has done kind of underlies, I mean, it fed into a lot of the profiling work that we've done in our OAuth profile, but the use cases are actually, I would say, a subset, and in some cases, they're outside the Venn intersection, if you'll allow me a Venn reference, because they are, as you say, I think they're more internal and they're more provider to provider, and the patient actually isn't in a lot of the flows.
And
so,
also, right,
yeah,
and then also Josh Mandel and John Murky, who are really involved with the FHIR HL7 specs, they're actively involved and participate in the working groups when they can.
Yeah,
and
John Murky's on a lot of the
very
calls.
critical feedback on the work that we're doing. So there is a real alignment where we think, especially on the patient-mediated, patient donation use cases that are becoming really, really strong, the PMI, the donation of genome data and that kind of work that they're focused on. So they're very focused on making sure those profiles align.
The reason I'm bringing up the current use case that we're working on, so I'm working on it with Jin Wen from McKesson. His colleague is sitting right here. And there's a number of flows that we're working through. And we've just been working through the very first flow, which is setting up provisioning of basic data prior to first visits to various doctors, but there's a number of flows coming, and we're sort of noting which Argonaut use cases by number that they align with. The difference is the Argonaut use cases don't have the patient in them. So it's actually a pretty big difference when you get right down to it, and that's where the patient-centric, privacy-sensitive actually kind of requires a lot more work. So not to say anything, I don't know, bad about the Argonaut use cases. From our perspective, they're just sort of, our goals require that we satisfy that need. So they're kind of additive with respect to the Argonaut use cases. So like use case 5 in Argonaut terms is sort of a subset of one of the flows in this use case.
And truly, you know, they have an entire community that they need to move to more restful, a restful approach. And they needed a way to start, but they realize that their profiles is kind of a ramp. They need a way to get onto the ramp to understand how to work the profiles before they can understand how to more securely lock them down, just to be able to get the first working. I mean, that was the attempts of their first round, but certainly as we move towards.
Yeah, I think there's a really good liaison structure among all of us because there's a large subset of people working on all the same things. So it's a really healthy interaction. Any other questions? I think we're a little bit over time, but maybe we can squeeze one in if there is. If not, maybe we can just discuss afterwards. Well, thanks very much, everybody, for coming.